majority is still practicing it under general anesthesia or regional anesthesia, but it's essentially a daycare procedure. It is virtually devoid of pain because the staples are well above the dentate line. All intervention is in the rectum, well proximal to the dentate line, in an area which does not have any somatic sensory distribution. So this is stapled anopexy. Next, I shall be talking about robotics and telesurgery. Now, pioneering work in robotics and telesurgery was done by urologists and cardiac surgeons. This is partly attributable to the fact that urologists and cardiac surgeons lack a simple laparoscopic platform. What it means is that for general surgeons, they have laparoscopic cholecystectomy where they can learn basic laparoscopic skills. Similarly, gynecologists have laparoscopic tubal ligations where they can learn basic laparoscopic skills. But urologists and cardiac surgeons, because of the inherent complex nature of their procedures, don't have a simple laparoscopic platform to learn laparoscopic surgery. And partly because of this, surgical assistant systems were developed which form the basis for robotic surgery. Now, surgical assistant systems are of two types essentially: surgeon extenders and auxiliary support systems. The basic purpose of both these systems is automated execution. What are surgeon extenders? There's this brilliant system which is devised by Intuitive Surgicals called the Da Vinci system. What it does is that it places the surgeon on a console at some distance away from the patient. The surgeon is on a console. He's looking into a viewfinder which gives him a three-dimensional view of the operative field, and this console is hooked up to a three-arm surgical manipulator which will actually carry out the operation. This is a surgeon-driven system. So the three arms of the surgical manipulator, two of them will hold instruments and one of them will hold the camera. And the surgeon will direct these three arms to operate. This is a very intelligent system. It scales down and filters motion, eliminates physiological tremors, and the instruments that are used have 7 degrees of freedom, which means that the instruments can actually simulate the human wrist in terms of movements. So movements such as intracorporeal suturing becomes extremely easy, especially for inexperienced users, and therefore advanced laparoscopic procedures like radical prostatectomies can be done with relative ease with the help of a robot. Some consideration must be given to proper trocar placement because, as you'll find out from the photographs I'm about to show you, these arms, the surgical arms of the manipulator, are very bulky, so they might clash with each other if trocar placement is not proper. There is one disadvantage of using a robot, and that is that you don't have tactile feedback. So many people will find it difficult, especially when intracorporeal suturing is being done, to find out if the knot is too tight or if it's too loose, because there's absolutely no tactile feedback. Similarly, it's difficult to ascertain if the tissue that has been sutured is being strangulated by the suture. A word about auxiliary support systems. Unlike surgeon extenders, auxiliary support systems work side by side with the surgeon. So the support system would be essentially holding the endoscope or retracting tissues. Now, the endoscope holding support system will be under the surgeon's direct control, either with the help of joysticks or foot pedals or an infrared head tracker. Now, this device will track the surgeon's head movements, and therefore the camera or the endoscope would be automatically focused on the area of interest. The endoscope could also be controlled by voice control. An example of an auxiliary support system is the famous ESOP robot. And with the help of auxiliary support systems, it is possible for surgeons to carry out major advanced and complex laparoscopic procedures entirely on their own without the help of any surgical assistance. This is a robot operating. You can see the three arms of the surgical manipulator, and you'll realize how important it is to have correct port placements, because if these ports are very close to each other, then these bulky limbs will actually clash with each other and making surgery very difficult. This is the console where the surgeon is sitting. You'll notice that the surgeon hasn't even scrubbed up for the surgery. He's just sitting at the console looking at the viewfinder, and the patient is actually some distance away from him. This is a close-up view of the console showing the viewfinder. This viewfinder will give him a three-dimensional image, as opposed to normal laparoscopic surgery where a person gets a two-dimensional image. Again, a close-up view of the robot on the cart. And this is the 7 degrees of freedom I was talking about. So as opposed to conventional laparoscopic surgery, the instruments can actually have 7 degrees of freedom, exactly simulating the human wrist. So complex dissections and movements are possible in difficult spaces with the help of robots. This is how fine the tip of the instrument is. You'll find that it's, as compared to a small coin, the tip is really fine, and very fine dissection can be carried out with such robotic instruments. Telesurgery is actually an extension of robotic surgery. Now, what is required is, imagine that the console is not in the same room as the patient. The console on which the surgeon is sitting is not in the same room as the patient. In fact, the console is not even in the same building, or not even in the same city or the same country. All that is required is a facility by which data can be transmitted from the console where the surgeon is sitting to the robot. And this has been possible with the explosion of broad bandwidth telecommunications. It all started off with a process called as teleconsultations and telementoring, where with the aid of duplex video transmission, which means that both audio and video can be transmitted simultaneously to both centers, teleconsultations and telementoring was possible, which meant that a surgeon sitting in Europe could actually guide a surgeon operating in Mumbai or Delhi step by step as the surgeon was carrying out a laparoscopic procedure. With broad bandwidth, we find that the resolution of images, the frame rate, both these have increased, and lag time or delay in transmission of images has gone down substantially. Telesurgery, as I was talking about broad bandwidth, ISDN lines or DSL lines, which are the integrated services digital network lines, or the digital subscriber lines. With these lines, it is found that transmission lag is less than 330 milliseconds, which makes a delay almost imperceptible to the human eye. And the first telesurgical procedure was carried out between Baltimore and Rome in about 2000, which was actually the introduction to PCNL in this patient, because percutaneously a needle was inserted into a hydronephrotic kidney. This needle was inserted by a surgeon sitting on a console in Baltimore, and the patient was in Rome, and subsequently surgery was carried out. The first true telerobotic cholecystectomy was carried out from New York to Strasbourg in 2001. This was with the help of satellite communication. It is found that because the stakes are very high, we must have dedicated lines of communication, like dedicated broadband lines or satellite networks for telesurgery, because a small delay or a lag time could make a lot of difference in the procedure. Therefore, we're now having newer modalities of transmission. For example, the University of Cincinnati had flown the first unmanned airborne vehicle, which was transmitting a dedicated signal for telesurgical procedures. I shall move on to NOTES, which is natural orifice transluminal endoscopic surgery. Now, this is a brilliant procedure, and one of the progenitors or the pioneers of this procedure are from India, Dr. Nageshwar Reddy and Dr. G.V. Rao from Hyderabad. What happens is that an endoscope is placed, this is a slightly more complex endoscope than we're accustomed to, is placed perorally into the esophagus and the stomach. The stomach is incised from within. The endoscope comes out of the stomach into the peritoneal cavity, and this endoscope has facilities for many instruments. And this endoscope can move around in the peritoneal cavity and carry out various procedures like appendectomy, cholecystectomy. So this is scarless surgery virtually, because there is absolutely no incision on the abdomen. Everything is taking place intraluminally. Instead of using the stomach as a conduit, one could also do this through the rectum or the colon or the cul-de-sac. This is a photograph of an intraperitoneal photograph, actually, of the endoscope coming out through the stomach into the peritoneal cavity. And this is a small schematic illustration of the endoscope with a separate channel for instruments which can actually manipulate, dissect, even take sutures. And once the procedure is complete, the endoscope with the instruments is withdrawn, and the opening in the stomach or the viscus is closed either with the help of sutures, staples, or a special stapling device or pins. Next, we'll come to radiofrequency thermal ablation of tumors. Now, what is done is that electromagnetic energy is converted to thermal energy for radiofrequency ablation. So essentially we have alternating high frequency electric current which is produced by a probe from a generator, and it is attached, the generator is attached to a probe. The alternating high frequency current enters the body through the probe, and it is sent back to the generator through a grounding pad. Now this current produces ionic agitation in the tissues. These charged ions follow alternating polarity and produce frictional heat. This leads to coagulative necrosis, and at temperatures above 60 degrees it leads to tumor death. Now, heating produced by radiofrequency ablation depends on the thermal conductivity of the tissue. Therefore, if you have a tumor which is sitting very close to a large blood vessel, or into a blood vessel more than 3 to 4 millimeters in size, because of the cooling effect of blood, this tumor, or at least a part of it which is very close to the vessel, will be spared. Something about the device: it's a 150 watt generator which operates at 460 kilohertz. The tip of the probe, there's a sensor which continuously monitors temperature, and current automatically is suspended at a certain impedance. This procedure is carried out under sedation, under local anesthesia. Ideal lesions would be less than 3 centimeters, not superficial as I said, and some distance from large bowel and vascular structures. Indications for radiofrequency ablation would be hepatocellular carcinoma when surgery is not possible, non-resectable colorectal metastases, and as a complement to surgical resection in colorectal metastases. But one has to be careful that in such conditions the radiofrequency ablation is to be carried out for a greater margin, because there are satellite nodules close to the colorectal metastases in the liver. It can also be used for small volume renal malignancies, especially which occupy one pole less than 4 centimeters, as an alternative to nephron sparing surgery, and they can be used in poorly resectable primary and secondary lung malignancies. This is a photograph of the needles, which contain multiple curved retractable electrodes. The electrodes are kept inside the needle until its tip is positioned within the tumor. This is the generator. This is the close-up of the needle as it opens up, and this is the tumor ablation actually in progress, because you can see the tumor, the needle has been inserted, it's opened, and then radiofrequency ablation is being carried out, and eventually coagulative necrosis. This is ultrasound guidance for radiofrequency ablation, procedure done under local anesthesia. These are the grounding pads through which current is taken back to the generator. This is CT used for guidance for radiofrequency ablation. On the left hand side, which is the right lung actually, you can see ground glass appearance around the tumor, which shows coagulative necrosis has taken place. And these are images which show the effects of radiofrequency ablation. You can see in the left lung a very prominent nodule which has been subjected to radiofrequency ablation, and after 3 months the picture, and after 1 year it's almost negligible. Finally, angioplasty for critical limb ischemia. Now, critical limb ischemia would mean when the patient has chronic ischemic rest pain, ulcers, or gangrene due to vascular insufficiency. Now, without revascularization, these patients will mostly end up with an amputation. Now, what can endovascular surgery do for these patients? Now, endovascular surgery, or stent placement or balloon dilatation of these segments, have been tried, and they show better results in claudicants as compared to critical limb ischemia, and this is the same for open surgery as well. Open surgery will also show better response in claudicants as compared to critical limb ischemia. Endovascular intervention is the treatment of choice now for suprainguinal disease, especially infrarenal aortic stenosis or iliac stenosis, where balloon dilatation has been tried. Angioplasty is the treatment of choice for stenosis or occlusion of infrainguinal segments, especially in the superficial femoral artery, when the area of stenosis or occlusion is less than 10 centimeters. And there's a new technique called subintimal angioplasty, which permits endovascular treatment of extensive infrainguinal disease. So even if you have a long segment infrainguinal, it can be opened up with subintimal angioplasty. I'll tell you what this technique is. First, this is This is angioplasty, routine angioplasty for the tibial artery. You can see a blockade in the photograph on the left, and this vessel has been revascularized. This is subintimal angioplasty. What is done is a guide wire is inserted into the vessel which is stenosed, and just before the stenotic segment it is directed against the wall of the artery, and it is poked into the wall. Now once it is directed against the wall, it dissects, it opens up the intima, and it dissects in a plane between the intima and the outer layers of the vessel. The wire has a floppy tip, and the rest of it is hard. The floppy tip extends for about 10 minutes. So as it dissects, the floppy tip forms a loop which is used for dissection. A catheter is placed on the hard part of the wire, and the dissection is carried out all along the long stenotic segment. And once the stenotic segment has been completely bypassed by subintimal dissection, the guide wire re-enters the lumen of the blood vessel, and therefore a channel is created in the subintimal plane. This channel is dilated with the help of a balloon, and long stenotic infrainguinal vessels can be recanalized by this technique. This is again another photograph of subintimal angioplasty. Just a word about endovenous laser therapy for varicose veins. Now, any intervention for varicose veins should abolish reflux, should improve cosmesis, should have low morbidity, and should have a low recurrence rate. Endovenous laser ablation satisfies all criteria. It's an OPD procedure. It's with a diode laser. It just produces heat inside the vein. This leads to the formation of steam bubbles that cause thermal damage to the endothelium and damage of the vein, thereby ablating the varicose vein. The procedure is as follows. It can be done both for the great saphenous vein or the short saphenous vein. The great saphenous vein is cannulated just above the knee. The short saphenous vein is cannulated just above the mid-calf. A guide wire is passed into this vessel. On this guide wire, a catheter is passed. The guide wire is withdrawn. Now, before introducing the laser, tumescent anesthesia, that is local anesthesia, should be given all along the length of this vessel. This helps to cool the vessel. Therefore, the heat produced in the vessel will not perforate the vessel. Now, through the catheter, a laser fiber is guided into the vessel, and the laser is fired stepwise while withdrawing. This is an illustration. You can see the catheter and the laser tip. It is introduced into the requisite site in the vein, and the laser is fired while withdrawing, so the varicose vein will be ablated. Finally, I shall briefly touch upon live donor liver transplantation. Now, the first such procedure was carried out in 1989, way back, in a child using a left lateral segment from his parent. This program is largely fired by the lack of cadaveric donor organs, but this carries a significant risk for the donor, almost 0.3% risk of procedure-related death. There's a very high morbidity associated with this for the donor, almost 10 to 67% incidence of post-op complications. Some of them are very serious, and it's a primary violation of the principle of primum non nocere, that is, first do no harm. You're actually cutting open the donor, a sacred, healthy, live donor, and taking half his liver away. There have been 3 deaths in America, 4 in Europe, 1 each in Japan, India, Egypt, and South America, and this is serious. And 3 patients who have actually donated their liver have required liver transplantations themselves, and 1 of them is in a persistent vegetative state. So the donor has to be very carefully evaluated. The donor, as I repeat, is sacred, should have no medical comorbidities, should not have a very high basal metabolic index, because that is concomitant with fatty liver. Should be a physical size match, compatibility test should be done, and he should be given a cooling off period, which means that he should not get into this as a heroic option, because the morbidity and the mortality is pretty high in these patients. Donors must be subjected to CT volumetry, CT angiography, MRCP, and a biopsy if necessary. The recipient also has to be very carefully selected. Should be end-stage liver disease, failed medical management where survival is not expected beyond a year. Should be seen in. The recipient could have non-cirrhotic metabolic disease. In selective cases of hepatocellular carcinoma, which satisfy Milan criteria, and in fulminant liver failure. I'll just briefly show you 2 illustrations before I wind up. This is a standard diagram of liver. showing all the hepatic veins, you can see that the middle hepatic vein is preserved. Let's say one has to do a right hepatectomy as a donor hepatectomy. So the middle hepatic vein is preserved, and the right lobe will be transplanted orthotopically into the recipient, and this is the recipient. You can see that the normal liver, the recipient's liver has been removed, and anastomosis has been carried out with the right hepatic vein, with the right portal vein, and the right hepatic artery, and the right hepatic duct, which is a bilioenteric anastomosis. With this, I think I'm out of the time assigned to me, and I thank the National Board of Examinations and IGNOU University for this lecture. Thank you.
What a captivating session. Thank you, Dr. Satvik. I'm sure the students would benefit immensely from your experience and knowledge. We would be back after a short break of 15 minutes with the next topic of recent advances in the field of pediatrics. Thank you very much.